Going to introduce our lovely speakers for today. We have Kimberly Berry and Kathy Murray.
Hey, thank you. Hi, good afternoon, everybody. I'm Kimberly Berry. I'm a family nurse practitioner. I have been in healthcare for over 16 years as a registered nurse. Initially, I worked in a long-term care facility for several years and then transitioned into a hospital inpatient care where I experienced a gamut of healthcare, primarily ICU. And then as a nurse practitioner, I have been in many, many different spectrums of healthcare. I've done outpatient neurology, I've done home health, been in long-term SNFs, doing this, doing overseas care in long-term facilities, and right now doing some annual wellness visits for seniors. The overriding theme of my professional service has been geriatric care in multiple different facets. Most recently, I have launched into opening my own group home in the community where we provide affordable housing for seniors. And so, as I said, the overriding theme of what I've done in my profession has been caring for seniors. I have also been a caregiver myself for an aging parent where I oversaw the care of my dad as he is aging. And I assisted with him staying out of a home, nursing home facility for several years as we endured dementia. And so geriatric management care, ins and outs of senior housing living has been something that has been a really near and dear to thing that's near and dear to me for the last, I would say, almost 2 decades of my life now. So, in regards to discharge planning, in the latter part of my professional career, I have been provider, giving out discharge instructions, writing discharge instructions, but I've also been on the home health portion, trying to educate and inform family members on execution of those discharge instructions, educating them on how to advocate more their family members. And so I think that this is a great topic today, and I'm glad that everybody's here to have this discussion with us today.
Thank you, Kimberly. All right, and Miss Kathy.
Hi, I'm Kathy Murray. I'm a social worker. I've worked in the community, all different levels of care. Primarily, my experience has been acute care and managed that social work staffing to acute care hospitals, rehab facilities, nursing homes in the Dallas-Fort Worth metroplex. We even worked in Houston for a little bit, but community staffing. So, but in my experience, I've worked in home health, I've worked in nursing homes. I currently am working with a hospice, and all of everything, every level of care has been a result of people needing medical care, health care, and that I have done discharge planning, working with acute care facilities and other facilities that discharge patients. It's given me an opportunity to learn more about what people need. And hopefully I could share some information about maybe what you need to do, need to know before you get into those kind of situations. And then once you are needing that kind of service, where do I go from here? I feel it's very important to look at all aspects from care to follow-up care. Expenses, what does it cost? How do I make the decisions about what things cost and what is my post-acute plan going to be? So I appreciate the opportunity to come here and share information with you all, and welcome any questions that will give you some information.
Great. Yeah. All right. Can y'all describe the connection between the importance of managing post-discharge of your loved one while avoiding readmission?
So, hospital discharge, I would say, is really just the beginning of recovery, right? Like, depending on why individuals are admitted to a hospital, the length of stay within the hospital can range from days, weeks to months. And as a result, recovery post hospitalization will follow suit with as a repercussion of the care that was received in the hospital, the length of stay that they had in the hospital, things of that nature. So in the elderly population, we see a lot of admissions or hospital admissions because of falls, UTIs, pneumonia, strokes. Those are among the top reasons for hospitalizations in the geriatric community. And as a result, depending on how well that individual progresses in the hospital, they may discharge home or they'll discharge to a skilled nursing facility, one of the two typically. But once again, recovery really starts right after we get out, step foot out of the doors of the hospital. And a lot of hospital readmissions happen because either medications are not taken correctly, follow-up appointments are being missed, warning signs are not recognized really early, and the home environment is just not safe. So managing post discharge instructions and things of that nature is super vital in preventing rehospitalization. And as caregivers, it's a really, really important role to not only understand the instructions that are provided to you, but stand as an advocate for the individuals that you are caring for. And as a patient too, being your own advocate for understanding what discharge instructions are and asking the appropriate questions. So recovery continues at home or in the facilities. And the caregivers, as I said, play a really critical role in order to reduce the hospitalization or rehospitalizations after discharge.
I think it's important to understand that some people have the luxury of having a planned stay, that may have a procedure or surgery that they plan to go in arrangements, and other people are going into a hospital following a traumatic accident or sometimes slump that happened that caused them to industrial emergency brings. No, sorry, y'all. With no expectation of we're learning how to use this. With no now I forgot what I was saying. Sorry. Right. So if you had the luxury of planning, perhaps you could take some steps and be a little bit more prepared. But as far as what supports a safe discharge is when you are active participants in your medical care. One of the ways that you do that is the communication with the medical staff, communication with the staff that's coming in, not only the physician, the nurses, the ancillary staff, such as the therapist, the social workers, and making sure that the people that you are talking to understand your needs. So I think in a lot of cases, there's some assumptions that take place in the hospital when an individual comes in and you have a certain diagnosis, and we know how to treat that and we'll take care of that. And yes, lo and behold, you're better than you were when you came in. But if the people in the hospital, if we don't know what constraints that you have at home, if you live alone, if you have financial difficulty, or if you just have some economic aspects that may prevent access to some kind of post-acute care, if we don't have all the information that is impacting you, then that will potentially cause an unsafe discharge. It's important that you think about having an advocate for you. If you're seeking medical care, not only do you hear people talk about, oh, I need to have somebody go to a doctor's office with me. Well, you definitely need somebody to go with you to a hospital because it's a lot of stuff going on. And you may be in the, receiving treatment. You may be in the bed for days. How many of us sit in a bed and don't walk and don't get up and aren't able to transfer, but whoops, we didn't realize we couldn't transfer or walk independently because we didn't give it a try before the day that we're supposed to be discharged. So it's the whole issue of a safe discharge plan is communication, is reaching out on day one and asking people, how am I doing? What am I going to need? And who can help me get what I want or what I want? Yeah. What I need for a safe discharge. That's important.
What are some ways to avoid risk after a loved one is discharged?
So one of the ways to avoid risk after discharge is to make sure that you have accurate and written information about your medication, about your discharge plan, about any post-acute care that you may need, and then who's going to provide that post-acute care. A lot of times when individuals go into the hospital, let's say that they did have a traumatic event, they fell, they broke their hip, they had surgery, and now they've had therapy in the hospital, and somebody walked in and said, yes, you need to go to a skilled nursing facility, or you need to go to a rehab facility when you're discharged. Well, okay, great. Is that the correct level of care for you? And who's going to pay for that? Do you have coverage under your insurance? Has that post-acute care been authorized by your insurance company? And how do you know that that's an in-network provider? Those are all questions that you should be asking and discussing with your physician and with your hospital team to make sure those things are completed and arranged prior to your discharge. And also that you have information about those things, that you know what is the plan, you know what it's going to cost if there's any out of pocket. You're making a choice about what facility that you want to use. I hate to say this out loud, but your doctor may recommend a provider for you, but that might not be the provider that you want to use. And you may have to discuss that with the physician and explain that this is the provider I'm going to use because this is the one my insurance pays for. This is the one that's closest to my family. This is the one that can provide the best therapy, and this is my choice. So remember that you are your own advocate. Your family advocates for you too, but you need to make sure that your choice is always heard and recognized prior to your discharge.
And just wanting to add to what Kathy said, just ways to avoid risks, like some tangible ways to avoid risks for rehospitalizations after discharge, right? I think that's huge because we see readmissions all too often, and it's a big problem. And it is linked to worsening outcomes in general for individuals after recurrent rehospitalization. So what do we do to avoid those rehospitalization? What are the tangible things that as caregivers and as patients, what can we do to prevent rehospitalization? I know Kathy did talk quite a bit about advocacy, right? It's really important to advocate for, listen, if you are the patient, listen to your body, listen to the signs that seem odd. Don't take them for granted and be very vocal about those things. It's very important. As a caregiver, you may see things that might look subtle and may be things that you don't quite understand, but make it known, voice your opinions. All too often, my patients come to me, and what I get often is that, hey, I don't get the time with my provider that you sit and you spend with me. Like, my doctor comes in for 2 minutes and is right back out the door. When they do come in, they hang on to the doors to let you know that they are about to be right back out there, right? So in advocating for your care and the care of your family member, just being really, really vocal and requiring your healthcare provider to listen to you, like requesting that and just making it know that that is your expectation. I will say I'm really, really firm with trying to empower individuals to advocate for themselves and the time that you should be allotted when you speak to your providers. So acknowledging your symptoms and acknowledging those things and making sure that it's voiced. Also, after each discharge, everybody leaves out with a packet. It might be 2 pages long, it might be 15. And sometimes it is a lot of information that seems very medical jargony, and sometimes it's super vague and as clear as mud. But spending that time to really sift through the discharge instructions, that's super, super important. And if you don't understand something, call somebody that might know. And resources are available right now, like internet searches, which I know some seniors are not the most keen on, but you can literally pick up a phone, a smart one, and say to certain AI assistants, which I know there's skepticism about, but say, hey, what does my discharge instructions mean? Like literally read what it says and it'll spit right back out to you and tell you what it means. So just being really just taking that discharge instructions, reading it thoroughly, trying to understand it. One of the other things I always do talk about with my patients is having an updated medication list at all times. Like once you go into the hospital, things might be discontinued, new medications might be started. I can't tell you how many times I see duplicates of medications that people are taking as a result of just lack of understanding of what discharge meds are on that packet, right? And they will go and they're taking an aspirin and been prescribed a blood thinner, right? And because nobody has said to them, take the instructions say stop taking that aspirin, but they can easily go and access that at the pharmacy. So they're still taking the aspirin and the blood thinner, the prescribed blood thinner, and some Advil that also thins the blood a little bit more, and the garlic because that helps the blood pressure, but it also thins the blood. So reading that instruction and making sure that all your meds are updated on your medication list that you have on your person is really, really important. Make sure that you attend your scheduled follow-ups, make those a priority. A lot of my patients that are retired and they miss appointments too. And I'm like, Miss Becky, what would happen? I was so busy. I was tending to the garden and the house needed to be cleaned. Those things are priorities. I get it. But the follow-ups, the doctor's appointments, those are really, really important for us to reduce the potential for rehospitalization. Making sure your environment is clear. Everybody over the age of 60, 65 years old, there are certain things that you need to look around your house and make sure they're not there. Rugs that are trip hazards. That's a big, big one. Making sure that you don't have things that you're going to fall over and your stairs are clutter free and you have proper lighting to go up and down those things. Making sure that your animals know that they need to not run in front of you. And if they don't know that, there might be a time that we may have to consider different types of animals in our home. So those are just things like I think that I always encourage individuals to think about when we want to reduce the risk of hospitalizations.
What are things we can do proactively as we care for our loved ones after they get home or released to a long-term care? So one of the best things that you can do for them is be there before they're discharged. You need to hear what the discharge instructions are, and you need to be a part of the choice. If it's your family member, you need to be a part of the choice for post-acute decision making. There needs to be a plan. There needs to be confirmation that the services are approved by your insurance and who's going to pay for it and how long can you be there. There needs to be that it's really important that if you're discharged on a Saturday, Friday night, and somebody's made a referral for you for, let's say, home health. Oh, by the way, that insurance company's not open over the weekend. So they didn't get off. Who's going to get insurance off during that time? How are you going to follow up on that on Monday? And how are you going to make sure that the company is prepared to provide those services? If you need physical therapy and you're getting discharged on the weekend and your services aren't authorized, then you're not going to have therapy until maybe Wednesday, maybe Thursday. And God help us if that therapist went on vacation. So, those are important things to talk about prior to your discharge. As far as help after your discharge, with the fact that you now understand what the discharge plan is, what the instructions are if you're going to a post-acute setting, making sure that that post-acute setting has accurate information for your medications, accurate information for your weight-bearing status. Can you transfer? Can you get in and out of bed? Who's going to help you with that? Can you go to the bathroom at 8 o'clock at night? Is there going to be somebody there getting you ready for bed? Are you going to be the one helping your family member? So those are questions to ask and to make sure that you're communicating with not only your loved one, but prior to discharge, are those plans in place? And then after discharge, or maybe before you arrive to your post-acute setting, talking with the post-acute setting and making sure they have the information that they need to take care of you. That's going to lead to a safe discharge for you and a much more comfortable care after your discharge from the hospital.
Just want to add to that. I know that you did mention like adequate medical equipment in the home, and that can be a big issue, especially as you said with weekend discharges and things like that. Medical equipment in the home, making sure that home health is able to come out and things of that nature. That's something that unfortunately we have to advocate for too. If you know that your loved one is coming home with a wound that needs to be addressed fairly soon and the discharge is happening on Friday, it is within your right to say, hey, if home health is not set up, we may need to stay here another day. We may need to stay here through the weekend until Monday when this is completely set up and made sure that it will have the services when we get home. Because it happens all too. I've seen patients go home without an oxygen tank, and that's something that they need. And the weekend came around and, then dispatch health has to come out, like EMT has to come out to provide oxygen therapy. So things like that, advocacy has to happen because it does fall through the crack. But other some tangible things to proactively do when patients get out or individuals get out of the home. As a family member, creating a daily routine for your care, your family member, or a patient, if you are the patient that needs to be cared for in the home or the person needing to be cared for, a routine where your medications are in your pill box. Like, what meals are you going to have? Like, having a routine set out prior to getting back to home, prior to being discharged, knowing, like, being really proactive about that planning of what that will look like. Making sure you're tracking certain things, tracking your blood pressure, making sure you're equipped to do that, or have someone there to help you to track blood pressure, track your blood sugar, track your weight, whatever those indicators are going to be. That's really important that you make sure that you have the things needed to do that appropriately, and get yourself geared up for therapy. Therapy is something that is not easy. Physical therapy or occupational therapy or speech therapy. And sometimes mentally people check out when they get home and it's time for physical therapy. I can't tell you how many times I see patients. They get from the hospital, they go home, and the therapist comes to the home therapy. They don't answer the door. They don't answer the calls. They don't, so being proactive about being prepared for those things, because that's what is going to lead to a better outcome and fuller recovery for individuals.
How do you deal with left focus? Well, I've actually never seen that happen. But, you have to be as prepared as possible. I think that if your loved one is alert and oriented and is capable of making a decision regarding their care, they certainly need to be involved, and they need to know what the risk factors are if they're making choices that aren't safe for them. And you use words like safe and risk, and make sure that you talk about what could happen in a poor outcome. There are times, though, when our patients or our family members may not have full mental capacity to make a good decision for themselves. They've been eking along and doing quite well. Life is good. They can get up in the morning, fix their breakfast, watch TV, do what they do throughout the day, and take care of their pets.
All right.
But they've been in the hospital. They've had some changes. Physically, they may be a lot weaker. Mentally, they may have experienced some trauma, or maybe had diagnoses that have had impact on their mental status. So at that point, you need to really focus on what is safe, what is not safe. So the real answer to that is, before this happens, that you are thinking about for yourself and for others, what if I can't make a decision for myself with regard to healthcare needs? Is there somebody that can help me with that? What do I want to have happen if I can't make a good decision, or I can't be the one to take care of myself? And start having those discussions with your family members, with your loved ones, because after you're in the thick of things, you're in the hospital, you've been treated, and the doctor walked in that morning and said, okay, good, you're great. See ya. And, people a lot of times are not prepared for that discharge day, even though they know they're going to eventually be discharged. They just think, oh, well, I'm not really well enough. I still feel bad. I still need help. And they just haven't processed about how that's going to take place. So if it's possible, start talking to your family members about these things ahead of time before you're needed, while you're healthy. Who's going to help you out? Who's going to make healthcare decisions if you need that kind of help? And try to be as proactive as possible. Afterwards, the key is safety. How can I help my mom, my dad, my aunt be safe? How can I make arrangements for that? And it may be that you physically can't do that for them, or you're not available to do that for them, but you need to reach out to the discharge planning team at the hospital, try to get some support in developing a positive plan for your family member. And then also, if there's post-acute services that a patient's going to be receiving, make sure you're communicating with your nurses, your therapists, and your social workers for that post-acute team to all band together and making sure that the care that they're receiving is supportive, and they're watching to see if your loved one is participating in that plan of care. It's very important if you get home from the hospital and you're not feeling well, but I don't think I'll eat lunch or breakfast. I might have a little bit for dinner. And oh, by the way, I'm diabetic, but I don't think that'll hurt much because I probably need to lose some weight anyway. So, there's a lot of justification for changes in behavior sometimes that we make and talk about to ourselves, but we don't really realize the full impact of our choices and our decisions. And all of a sudden, you went to the hospital, or you got sick, you went to the hospital, you got a little bit better. Now you're a lot worse because you need that extra support, and you didn't realize that the choices that you're making are hurting you.
Okay, well, to piggyback off of what you said, but also the question entailed, what do you do when a patient or a family member is not cooperating with instructions? And I know you said you've never experienced it. I know that was sarcastic, but I too have never experienced that. But this one was a personal question to me. As in my introduction, I mentioned that I was a caregiver for my dad, who suffers from dementia. And so he lived with us for about 5 years. And as his disease continued to progress, there was a lot of resistance. There was a lot of apprehension. There was a lot of difficulty in getting him to do what needed to be done. And it's hard. It's hard for caregivers to see that. It's hard to be a caregiver and a child of someone who's dealing with this stuff. It's of course is equally as hard for the individual. Though he had gotten to the point where his memory was probably like 5 minutes of a span, and then it got reset and then would go up. But it was challenging for him. So, but it's not always dementia. A progressive illness like dementia is not always the reason why individuals are uncooperative. So we have to ask that question, like, why is the resistance happening? Why are they being uncooperative? There are a lot of other reasons. There are a lot of reasons. Fear, pain, depression, dementia, as I said, lack of sleep, insomnia, overall delirium. Like, these are all real reasons why people just are resistant to care. And sometimes it's readiness to go. It's readiness to leave and being exhausted with the back and forth, being just the product of the healthcare system, and people just are ready to go bye-bye, right? And so as a family member or a person experiencing some of these desire to be resistant, or just experiencing not wanting to comply with the healthcare orders, we have to sit and ask, like, what is the underlying reason why this is the non-compliance is there? A helpful approach for caregivers is to really be empathetic, right? Put yourself in their shoes too and see, like, if I have to take medication 4 times a day, a handful in the morning, 2 in the afternoon, like that's not cool. I wouldn't want to do it. So that resistance can happen as a result of that. So as a caregiver, listen first, really listen. And when we say listen, actively listen to your family members' concerns or complaints. And if it's yourself that you're dealing with, listen to yourself, because we can tell ourselves a bunch of stories sometimes. It's not true, but we have to be introspective about how we feel about where we are in our healthcare journey. Offer choices instead of commands. I had to do this very often to my dad because I was a child, even though I'm in the role of like making sure everything is together. But I had to say, okay, dad, are we going to have our breakfast first, or are we going to get dressed, or when are we going to take this shower? Is it before or after dinner? Giving these choices so that he felt still independent, still autonomous, still feeling like the adult in this relationship, staying very calm and respectful. Oh wow, that one can be difficult when you have somebody who is so headstrong and does not want to comply, and being calm and being very respectful of their wishes. That is difficult. But once we establish that understanding, it can go a very, very long way, and involve family members and involve your healthcare team when managing individuals who are challenging or are cooperative. Like, this is not, it takes a village. It takes a village, truly takes a village to do life sometimes and to do recovery and all the things. So reach out for help, and we are in it together.
What are examples of ACAP services that we can go on to ensure our loved fully acquired continues after this?
I'm assuming you're talking about post-acute care here. I mentioned home health services. Depending on the level of functioning, an individual may qualify for skilled nursing or acute rehab. You just really need some direction from your physician and from the healthcare team to make recommendations based on your family member's level of care need, to then make a decision about what services would be most appropriate. There are a lot of services out there, but it's hard to understand what a person might meet criteria for from a medical standpoint, and then again, what would be paid for, and then how do you access that? Sometimes, well, all the time, if there is a need after you get home from the hospital, you definitely need to follow up with your PCP or the physician that you were instructed to speak with or follow up with. You definitely need to involve your healthcare team if you need extra services that weren't arranged prior to your discharge. So again, staying in touch with your medical team, making sure they know what the needs are is very, very important.
Yeah, and I agree. There are many services that are out there for seniors, and unfortunately, they are not always easily accessible. That's a part, whether it is because individuals make too much money with their social security, or they have their assets and they cannot qualify for certain funding or certain things. So there are, depending on whatever discharge needs are, there typically are resources in the community that can help to meet some of the needs, sometimes through churches, sometimes through local organizations. But I couldn't say with certainty and that patients are able to get these resources as easily as they typically need to. It's really unfortunate sometimes. But once again, as Kathy said, advocating, knowing what your needs are, expressing them to your healthcare provider, your healthcare team. Social workers, case workers are really important, essential when you're in facilities to kind of anticipate those needs and help getting some things set up for you, like the home health and all that kind of stuff. But some things that even within my group home that some of the guys are able to take advantage of is meal services, like the Meals on Wheels. I think that's an excellent service. Nutrition is huge, and the meals are not always the greatest, but they are meals. And I really appreciate that my guys get fed on a regular basis because of that. There are transportation assistance services, mostly a lot of the time through different Medicare insurance plans. If individuals have a Medicare Advantage plan, typically they provide transportation services. So that's a really, really good resource for a lot of individuals. Home health aides that can come out. Sometimes some health insurance plans do provide assistance with that. And a huge resource that I don't think most of my patients take advantage of is Silver Sneakers, which is a program or plan through your through your health insurance plan for a free admission to a gym. And that can support recovery as well as doing, of course, physical therapy when they come in. But after physical therapy, what does that look like for your mobility, for your activity, things like that? We need to get out in the community and continue doing that. So I would say anybody who's on a Medicare Advantage plan, typically I'm like, are you enrolled in Silver Sneakers? Because you could have a free gym membership. And my little ladies, they love the aquatherapy and the Zumbas and all of that kind of stuff. So, we have to be creative in how we research some of the resources that are in the community for patients, because it's not as easy as it should be sometimes, but they're out there. It's out there.
I think it's important that you and the patient explain what your needs are, what your concerns are to the healthcare provider. Because if your discharge planner, case manager knows that you're having a specific difficulty, there may be some financial need involved, there may be some programs that they can make referrals to. They can look at, for example, some people may be eligible for VA services and they never accessed that. They didn't realize that. They didn't know how to take advantage of that. With the health insurance, United Healthcare, and some of the other plans, they offer case management services that a nurse will actually come back or come out and do an on-site visit and do another assessment to see how the person is progressing and the level of care needs. If there's changes, you could talk with them about that. So the biggest thing is communication. It's communicating with your physician, communicating with your healthcare team, and saying, hey, this is not working. I need some more help. Or my mom or dad needs this or that. And who would you talk to if you needed these services? So they may trigger and be able to give you a referral to a company or individual that can provide some support services. But like you said, there are services out there, but it's how to access. And not everybody is eligible for post-acute services or for services in the community. But it is important to at least rule that out and to see if there's something that can provide that care and support.
We can turn it over to y'all for any questions.
If you try and advocate for yourself, but no one seems to listen, is there an advocate, not a mental health person, but maybe an advocate maybe you can sort of reach out to? So I used to advocate for people on LPC from New Jersey, and I advocated for people, and I had more success advocating for others than I do for myself. I'm getting to do a slam.
I think that's always the case, right? We look after others. So in Dallas County, it may be that a good start would be the senior source. That would be a good community care case management program that you could reach out to. And if they can't help you, then they may be able to make referrals. Also, 211. You can call 211 and say, I need this or that. It is a United Way program, information and referral.
I tried to one, just fast that out.
Right. Yeah. Mm-hmm.
I'm trying to see that's for
Mm-hmm.
maybe that's a name.
Mm-hmm. Oh, that's good. She said findhealth.org. It's a website, but they have tons of social services agencies and different programs under different categories. It's a great place to look. Thank you.
I also want to say in Declan, Texas, they have for seniors, they have that type of program that's 7 hard meals.
The SPCA does a program for seniors for pets. So, remember what Pat's saying is exactly true. It's a window in time that we're seeing from a hospital standpoint. And the problem a lot of times is you are working. You're working and you get off work at 5 and you come to the hospital and your loved one says, the doctor said I'm doing great. And no, I'm not going to need any of that stuff. I'm really able to get out of bed. I'm just tired right now. And so thank you for bringing that up. It is really, really important to try to take some time off to meet with the care team and to have factual information about what is actually going on, what are the recommendations, and what is the ability of the patient to meet those expectations upon discharge. There are people that work on Saturday, Sunday. Another thing I tell my patients is a lot of times you've got extended family that turn to you and go, oh, I want to help. I really want to help. Whip out that calendar and pencil them in from, Saturday from 1 to 4. Thank you very much for your help. Every Saturday you'll be there, right? And it's not that they didn't want to help. They did want to help. But so many times we say, oh, okay, thank you. Yeah, I could use help. But then nobody defines what that is and when they're available. So make use of your extended family and try to draw them in to be that help. Okay.
So what considerations do you or the doctors make when you're thinking about sending someone home versus sending things do they need to make that decision?
So I can say, as being responsible for many discharges, it depends on how the acuity of your stay right in the hospital, right? Someone who came into the hospital for a stroke will likely have a different disposition than someone who came into the hospital for UTI. Both very common reasons for admission in the hospital, for hospital admissions, but their recovery and discharge planning is going to look very, very different, right? So if a 60-year-old individual comes in with a stroke too, and also 85-year-old grandma comes in with a stroke, their disposition might be different. The 60-year-old may recover well enough to go home, whereas my 80-year-old lady might not, or vice versa, depending on the severity of the stroke, right? So depending on how well the recovery while in the hospital, that is a huge determinant of where you will be discharged to. If we deem that you will need additional skilled nursing resources, we will send you discharge to a rehab facility. And then once you get to the rehab facility, a reevaluation is done by the providers there to see the length of stay and things of that nature. Do we always get it right? No, there are times that individuals need to go to a skilled nursing facility and they are discharged home. And that's another reason why sometimes readmissions occur. As she mentioned, some of the times we don't know what people are walking into when we discharge them home. So they're really not set up for success. But it's usually the acuity of your reason for admission and how your recovery in the hospital is. That's a huge determinant of where you will be discharged.
So you don't ask this.
No, you do. And I think it's very important that you're communicating with your care team about your prior level of functioning. How were you able to function at home? What are the recommendations for the care team? There's very specific criteria that we look at for patients that may meet criteria for, you hear that word all the time, those words, meet criteria. A patient may meet criteria for acute rehab. A patient may meet criteria for skilled nursing, or a patient may not meet criteria for those things, but may benefit from home health care. So you've got to communicate to your care team, what was your prior level of functioning? What were you able to do? If you're not able to do those things now, you need to be an advocate for yourself and say, I cannot do those things. I'm not safe to go back home if I'm able to transfer in and out of bed. I live by myself, or I live with a spouse who can't lift me, and I need a higher level of care than returning back to my home. So it is that window in time, communicating with your care team and being factual about what you need and what you had before and what you need now. And it's a great help when you have somebody that's able to come and help you at home. You also want to take into account, do you need a nurse to monitor your wound care, for example, or your whatever else those nurses do.
Vitals.
Thank you. Thank you. I know they do something in here.
It's a long list.
But you need to know, if you need somebody to take care of your medical needs, if you need somebody to provide physical therapy, it is wonderful to have your family, your extended family available to help, but they are probably not the licensed individuals that you need to be able to deliver care to you. So you just need to have that factual information given to your care team. You need to see what are you able to access with regard to your insurance coverage, and you need to get it authorized at the level of care the physician is recommending. May I just share a story about a friend of mine whose mother had a stroke, and her progress in the hospital was okay, but they came back to her and said, it looks like your mom needs continued therapy. You could probably go to a skilled nursing facility. Well, this friend of mine, who's like an incredible advocate for everybody in the world, informed them, and she actually had been reaching out from the day one when her mom, but that's another story, informed them that her prior level of functioning was of a much higher level. She was able to drive. She was able to care for herself, wash her clothes. She was retired, but all of her daily activities of daily living, she performed independently, and she could not do that. If she went to a skilled nursing facility, the level of therapy that she would get would be approximately an hour a day. If she went to an acute rehab, she would start off with 3 hours of therapy per day with multiple disciplines and nursing and physician seeing her daily. So my friend, again, who's a great advocate, pointed that out, reached out to the insurance company, and got authorization for acute rehab for her mom. What that does, a couple of things. One is a person is placed in an appropriate level of care post-acute hospital discharge and given appropriate therapy for the time that is authorized. And in a acute rehab facility, you're evaluated every day on the progress that you're making. And you have to demonstrate that progress. The insurance has to see it for them to continue to pay for that. Well, she did it, and she made great progress, and she was able to return back home, and she was able to go through a driving program. It was very much the success story. If she had gone to a skilled nursing facility, not that a skilled nursing facility is bad, they are great, but the level of care wasn't appropriate for her prior level of functioning. And she had healthcare insurance that would cover acute rehab. So all of those things, again, are very important that you take into account and get somebody to be your advocate and make sure that you're getting access to appropriate level of care when you're discharged.
Any more questions?
Thank you.
Thank you all for coming.